in behalf of Canadian Studies, it's a great pleasure to welcome all of you. Also like to welcome, if he's not here yet, he should be here pretty soon, Scott Parker, who's Canada's Honorary Counsel in the state of Utah, and in his own right has been a leader in Utah's healthcare industry. As far as we know, we have the largest enrollment of Canadian students of any institution of higher learning in the United States, and would like to welcome some of those students here with us today. And we'd like to give special thanks to the Palmer family, who have been so generous in funding this annual lecture. We have many of them in the front rows here, and they've traveled from all over the western U.S. and western Canada to come and welcome, and thank you so very much. We appreciate it so very much. Our speaker today is Director of the Institute for the Study of Canada at McGill University in Montreal. She's a political scientist as well. Recently served as a visiting scholar at the McGill Institute of Health and Social Policy in the Faculty of Medicine at McGill University. She's a graduate of Université Laval in Quebec City. Received her master's from the Patterson School of International Affairs at Carleton University in Ottawa, and her PhD from Northwestern University. Her husband, Pierre Martin, is also a noted political scientist at the Université de Montréal, and they are the proud parents of triplet sons who are now 10 years old. Our speaker has published widely on issues of health and social policy. She's one of North America's foremost experts on Canada-U.S. health issues. She's also a noted commentator on Canadian political issues. And as many of you know, Canada will hold its own national election on October 14th. Last night they had the leaders' debate in Canada in the French language. She commented on that. CTV, a national TV network, had her on. They set up a studio in Salt Lake City. The background was the temple. And as the Canadian host came on and saw the background, he said, "Are you in Moscow?" But anyway, they got to see the beautiful temple in the background, and she's going to do the other debate tonight, which will be in English, coming from Ottawa. As she said, she'll be the only one not watching the vice presidential debate here in the United States, since it's exactly at the same time, both debates going on simultaneously. This is her first visit to Utah and, of course, to BYU, and we hope that she is having a great experience. It's a pleasure to introduce to you Antonia Maioni.
Thank you very much, Professor Fry, for that lovely introduction. And I am having a wonderful time here in Utah. I knew it was beautiful, but I had no idea just how beautiful it was. And I've already, you don't know this, but I've already decided to come back with my kids in tow, so we can travel around this beautiful state and also hopefully get down to the Grand Canyon. This is a really wonderful opportunity for me to be here. And I think that Earl didn't know they were going to call an election right in the middle at the same time as I promised to come to Utah, and certainly the networks didn't know that, but I didn't want to miss this terrific opportunity to visit him and to visit Brigham Young University and to give this distinguished lecture. And I'd like to thank the Palmer family as well for being here today. Whenever I come to the United States and talk about healthcare, I'm reminded of when I was a graduate student, before I had the triplets, who taught me a lot about healthcare as well. But when I was a graduate student here, or in Illinois, when I arrived, I was given a card that said, "Welcome to the United States," and everything else, and then it said, "You are now a non-resident alien." And for a Canadian, I thought, what, an alien? You mean like from outer space? I'm from outer space? And it got me thinking that often in the United States, when you kind of come in and try to present what Canada's healthcare system looks like or others, people think, yeah, it is kind of from outer space. It's so alien. It's so foreign to what we know here in the U.S. But I think there are a lot of lessons that in particular Canada has for the U.S. and vice versa. And I think that Canadians also tend to sort of look a little bit too inward at what they have and to not try to consider how some comparative lessons might help. Not necessarily to find solutions, the magic pill that everyone's waiting for, but at least to put things into context and to understand that there are people all over the world and there are people all over the United States who are grappling with some of those same issues. It is true that when I went through the process of giving birth to these lovely boys, and in the years since, you can imagine, I have become, I guess this is a social science term, a participant observer of the healthcare system because I have been participating in it a lot and observing as my 3 little boys go through their ups and downs of childhood. Today I wanted to talk to you and hopefully glean also some information, insights for myself on what Canada and the U.S. can learn from one another. And what I'd like to do, and I think where we should go in this cross-country learning, is to move beyond what has happened in the past generation. For the past generation, we've been talking about the Canada-U.S. comparison as, focusing on the other country, on each other as either, nirvana of what everything should look like or of everything that is bad. So you have proponents of national health insurance in the United States who say, look at the Canadian model, look at that single-payer model, that's the model for us. And you have Canadians saying, oh my gosh, we would like to reform our healthcare system, but no two-tiered healthcare is in the United States. So I think we have to move beyond that to sort of think one is a model for the other and to think about some specific lessons for each of the countries, because each of the 2 countries' healthcare systems is based on such different principles of funding and access to care that the challenges, even though some of the challenges are similar, are playing themselves out differently in both countries. Canadians, and maybe the Canadians in the room can back me up on this, do have worries about their healthcare system. But they're not faced with the same day-to-day problems in accessing care or in paying for that care. Just a little anecdote I have from last week is one of my children was ill, not feeling well, bad headache, which is odd for a 10-year-old, heavy fever, high fever, just, the vomiting. I won't go into all the details, but just not, pas dans son assiette, as we say in French. And when I called his pediatrician, she said, oh, well, it could be a virus, it could be a bad headache, could be a migraine, she said, or it could be meningitis. So I want you to take him to the emergency room right now. She called ahead to the emergency room. We got to the emergency room, didn't have to wait. They looked at him right away. They kept him there all day, ran through all the tests. And then at 5 p.m., it was about 5, the nurse came in and said, well, don't wake him up, but as soon as he wakes up, just go home. I didn't fill out a form. I didn't pay anybody. I didn't have to talk to any kind of insurance thing. I just walked out of the hospital with my son, and he was fine. And that night, I did get a call. I got a call from the pediatrician asking how he was doing. So in a sense, as a mother, I'm not faced with those day-to-day issues of if my child is ill, will I be able to pay for the care, or will I be able to get access to the care? But that doesn't mean that Canadians aren't concerned about healthcare is rationed as a public good. And that's what we have in Canada. Healthcare is a public good, and so it is rationed in a different way than in the United States. And one of the challenges that we have is that because we prioritize access to care on the basis of needs, the question is, how do we determine that need? Who makes the decision about who goes first at the emergency room or on a waiting list? And what about all these waiting times that we have for non-urgent procedures? They may not be medically urgent, but they may affect someone's quality of life and indeed ability to enjoy the years they have ahead of them. And this is why the Conservative Party that is now in power in Canada was able to make some significant inroads across the country by saying that the problem with the healthcare system is that we have to rethink perhaps how we prioritize who gets what, when, and where, which are basic political questions to ask. And we've now had the courts become actors in the healthcare system, and we've had court challenges that are ongoing right now in Alberta and British Columbia, and that have already been decided in Quebec about people's right to have access to care even if they're judged to be on a waiting list. And some people don't feel that that's a proper way, don't feel that the waiting time is appropriate, don't feel that that's the way they should have access to care. Now, in the United States, it's not as if there aren't big challenges to healthcare as well. And what's interesting is that it's a political issue at every level of the political spectrum in the United States, and it's a political issue almost behind every other domestic issue. So right now, everyone's very preoccupied with the economy. But to be preoccupied with the economy in the United States is to be preoccupied about healthcare, because it's economic status and economic well-being that determines if you have access or if you're able to pay for the insurance that gives you access to healthcare. And so that's a very important backdrop, if you will. And Americans are becoming a little dissatisfied, or in some cases a lot more dissatisfied, about the kind of moves, the kind of ways that healthcare is moving forward in the United States. And my Canadian colleagues like to say that the United States has two-tiered healthcare, which I think is not the case. I think Americans have 300 million tiered healthcare, which means that every American has a set of access and cost issues that are different from every other American, and it depends on your socioeconomic status, it depends on your state of residence, it depends on whether you're eligible for a public program, it depends on what your employer is prepared to give you, et cetera, et cetera, et cetera. So every American is actually very different from every other American, and I think that in Canada we tend to not understand exactly how the U.S. healthcare system works in that way. But it does mean that the problems in the United States that Americans have are problems that are associated with healthcare as a commodity rather than as a public good. And that's the essential difference with Canada. So we have rationing, we have cost issues that have to do with the public good that is healthcare, and in the United States, problems with access, problems with costs that have to do with the healthcare as a commodity, and the lack of equity that sometimes creeps in to the U.S. healthcare system. So in the spirit of healthy comparison, I'd like to now just turn to a couple of important questions that can give us some comparative reference points about Canada and the United States, with the goal of understanding the two healthcare systems and how the comparison can help us understand it more. So what exactly are the differences in the two countries, and how did we get there? Why is that the case? And it's interesting because Canadians like to make a lot of I would say, banter and chatter about how different they are than the Americans. But at the end of the day, if you look at it historically, economically, socially, and politically, they are in effect very similar. So Canadians and Americans share a lot of important traits that other countries do not. And I say that as a social scientist, not as a proto or pro-American or anything else. I say it as a social scientist. And even though we share a lot of these differences, these similarities, health insurance is a big difference. So one of the most important social policies in both countries is radically different in Canada and the United States, even though we share a lot of similar traits. And so as a social scientist, I've always been fascinated by that puzzle. And I think that the reasons that they are so different have to do with political factors. And we can discuss this if you like, I don't really think that there's some kind of gene in Canadians' DNA that makes them more prone to be supportive of national health insurance or more prone to want quote-unquote socialized medicine. I think that it is the result of some very important political decisions. It's the result of some pretty fundamental differences or the way that our institutions are shaped, that we have a federalism that is different than federalism in the United States, and that we have political parties that are different than political parties in the United States. And I can tell you, after watching that debate last night, I don't think you could have a debate like that in the United States, in which there were 5 political parties, and 4 out of the 5 were ganging up against the Prime Minister, who is a conservative, and calling him, I don't want to tell you what they called him. They called him some pretty nasty names, and I think Moscow did come up. Somebody mentioned Stalin, so I think there was something in that particular exchange. In fact, one of the reasons that healthcare in Canada is different than the United States is because of the provinces. So there is substantial autonomy in the provinces to allow these kinds of innovations, these laboratories of democracies, which is the way they are supposed to function in classic federalism. And at the time that Canada developed sort of a national hospital insurance and then a national medical care program, there were 2 important factors. One is that it came out of the poorest, most rural province in Canada, Saskatchewan, which had a lot of experience with cooperative movements. And the second thing is that it was spearheaded by a party of the left, the Social Democratic CCF and now New Democratic Party. So there were some pretty precise political markers, right, that happened that led to this development. But it wasn't an easy development, and it wasn't an overall, carte blanche that everyone agreed to. There were a lot of political struggles and a lot of political divisions about where to go in healthcare reform. In 1962, the doctors staged a strike to prevent the government from implementing its medical insurance plan in the province of Saskatchewan. And when the federal government was debating what to do, there were many people who got up from the province of Alberta in the House of Commons and said, we don't want our healthcare system to look like Saskatchewan's. We want it to be on a voluntary basis. We're starting our own program. We want that to be the model for Canada. So there were a lot of different points of view. And now, now a generation on or a couple of generations on, we say, oh, it was destined to be like this. It was not destined to be like this. It was the result of some important political decisions. And it meant that our healthcare systems went in two very different directions. But we shouldn't lose sight of the fact that it wasn't just predestined, that there were some important political decisions that led to the development of this kind of universal hospital and medical insurance, and how that model was diffused across the rest of the country. And one of the reasons it was diffused was that the federal government decided to share in the cost. And the federal government at the time was a Liberal government that was trying to fight off the left, that was actually in the center and losing support, and was trying to become more social welfare oriented in its outlook. So what do these plans look like today? How is then Canada, the Canadian healthcare system, designed? The fundamental difference with the United States is that every legal resident of a province is insured. So it's not like you have to go through the motions of comparing health insurance plans and then finding a broker or whatever. You are legal residents of your province. You are insured under your provincial health care plan, and you are eligible for your provincial health card. And provinces are the basic administrators of these healthcare plans, right? So provinces, it's not the federal government that tells provinces what to do. Provinces administer these plans, but like the saying goes about Caesar and giving back to Caesar, because the federal government sends money to the provinces, there is a sense of obligation to uphold some of the principles that the federal government thinks are important in healthcare. So nothing is ever free, right? There's no such thing as a free lunch, and certainly the provinces have realized that because of the money that the federal government sends them, they are obliged to do certain things with their healthcare plans. And basically it means that they have to abide by 5 principles that are in a federal statute called the Canada Health Act. And those 5 principles stipulate that provincial health plans must be publicly administered, they must be universal, they must be comprehensive, they must be portable across provincial boundaries, and here's really the crux of the matter of the debate today, they must provide equal access to care based on need alone, which means that money cannot be an object in deciding who gets care, right? Money cannot be an object. So that's why in Canada you can't have user fees, you can't have co-payments, you can only have private insurance on a narrow range of services. What's covered in the Canada Health Plans? Well, all quote-unquote medically necessary services. So services that are considered to be medically necessary that are delivered in a hospital or considered to be medically necessary delivered by physicians. And again, accessible on the basis of medical need. Now, some types of services which have become more and more important, like complex diagnostic procedures, dentistry, or the very expensive outpatient prescription drugs, may not be covered by provincial health plans. So we have, we have provincial health plans in which what's covered is covered at 100%, first dollar coverage, which is why no money changed hands when I went to the emergency room with my little boy, or when I left. But outside of that, it's not covered. So outside of that, if the doctor had written a prescription for me, I would have had to pay for that prescription at the pharmacy. Or if I had dental problems, I would have to pay for that out of my private insurance or my own pocket. So there are a lot of gaps, more and more, in some of those services. There is private supplementary insurance in Canada. Most people have it through their employer, but it can only cover what's not covered publicly. So you can get private insurance for eyeglasses, you can get private insurance for dentistry work, but you can't get private insurance to have an open heart surgery, and you can't get private insurance to have to deliver your baby. So if you need those kinds of medical procedures, you must go to the publicly funded plan. How is it paid for? Okay. This is another myth, I think, that happens here. Healthcare is not free. Nothing is free, and healthcare certainly isn't free in Canada. It's paid through by provincial and federal taxes. And these taxes are very high. In Quebec, currently, we're taxed at 40%. So 40% of our paycheck or more goes towards taxes. So we're the highest tax jurisdiction in North America. So people in Canada tend to complain about taxes, and when they complain about healthcare costs, they're complaining on a collective level about the amount of money that's spent on healthcare that comes out of our taxes. Now, certainly a dollar is a dollar. If it didn't come out of our taxes, it would come out of our pockets in another way. But the sense is that Canadians recognize that they pay for a very expensive healthcare plans, and that's why they become pretty vocal in making, why isn't it why aren't some of the things that we have in our healthcare system done better? Now, physicians are reimbursed. So physicians in this kind of a plan are interesting because they retain autonomy. They retain autonomy over their professional lives, and they retain autonomy to a certain extent, and I'll explain in a moment what that means, over their economic situation as well. The vast majority of physicians in Canada are reimbursed on a fee-for-service system. That means for every fee they perform in their offices or in their hospital, they're reimbursed. So it's not like in the United States where doctors are at the mercies of HMOs or insurance companies or anything else. If a doctor has a billing number, they take care of you, and then they bill the provincial government, who's usually good for the money, as they say. Don't have to run after bad debts, don't have to have collection agencies at anybody's door. So doctors have a relatively good financial situation in that respect, that they are autonomous in their professional capacities, and they're autonomous in their financial capacities. The problem is that if they see a patient and they have to say to the patient, I'd really like to operate on you, but there's a waiting list for your procedure, that's curtailing the doctor's professional capacity. Even though it's the doctor that's deciding where you sit on that priority list, right? It's not some bureaucrat in a provincial capital. It's the doctor that says, Mrs. So-and-so should be, has this kind of a problem, and I figure the medical need is whatever, and where she should be on the waiting list. So the doctors control that, but it does frustrate them in some way that they can't perhaps do all they can do right away. And the second thing is that in some provinces there are caps on their salaries. So the province of Quebec is a good example. We have a cap on specialist salaries, so above a certain amount of money. Doctors are only reimbursed at a quarter of the rate of the going rate, so some just kind of shut their offices and play golf, which is not good for the healthcare system because people are on waiting lists. They need their services, so it's sort of a catch-22 situation. Other provinces don't have these caps. Alberta doesn't have caps, for example, so specialists can do a lot better financially. Generalists, however, GPs, don't make that much more in the United States than they make in Canada, so GPs actually do a good business in Canada, relatively speaking. Hospitals, too. Now, this is another sort of conundrum. Hospitals are voluntary organizations in Canada. They are not owned by the state. There's no kind of, they all have independent boards. They can do fundraising, but they have their operating budget comes from the provincial government. So the provincial government decides, in consultation, obviously, with the hospitals, what the global budget will be. And then the CEO of that hospital has to live within the budget, right? Hospitals aren't allowed to make a deficit, which is very difficult when you kind of, you have this global budget and nothing else. You can't get any other revenue. That's your revenue. You can fundraise for specific, if you want to extend pavilions or build new wings, it has to be approved, but you can do it. So hospitals are a little bit under the gun in that way as well. And when we had a lot of hospital closures throughout the 1990s, it was basically provincial government saying, well, your global budget this year, zero. So hospitals had to close their doors in many small rural communities. So what's fascinating is that if you think about the challenges and the landscape of healthcare in Canada, there are a lot of differences with the United States in that sense. And I tend to tell my students, and I know that at Earl must, Professor Fry must as well, that in fact the United States went way ahead of Canada a lot earlier. FDR's Social Security Act, Harry Truman's fight for the fair deal. Healthcare was a component in those particular battles. Left to the side in the 1930s, come to the fore in the 1940s, whereas in Canada, not a lot was going on. Not a lot was going on to face the Depression, and certainly not a lot was going on in the 1940s to bring healthcare to the fore at the national level. So the United States went further, but ultimately the dream of a national health insurance scheme, a plan, failed. And then reformers fell back on the idea that we should insure certain types of people, so the elderly, the disabled, the very poor and indigent, through Medicaid, through Medicare. But the sense of the universality of it somehow got lost, and that's what we picked up in Canada. And in the United States today, then, in sharp contrast, to Canada, people's employment status determines their access to care, and their employment status also affects the access to insurance that gives them the access to care. So all of it comes down to some pretty basic economic dollars and cents, or if they're eligible in some way to be part of the Medicare program, the Medicaid program, the S-CHIP program. But these programs are huge. These are huge government programs in the United States. 30% of Americans, or 1 in 3 Americans, is somehow covered in some way through some of these programs or through veterans and military. And I think Canadians recognize the extent to which the United States has this administrative capacity to run something as big as Medicare, to run something in the individual states as big as Medicaid or S-CHIP. I mean, these are huge programs. They're much bigger than any government program in any province in Canada. What's really interesting, too, is that the existence of Medicare and Medicaid, so the existence of these government programs in the United States, they're in sort of the same medical game, if you will, dominated by private interests. And that makes it really difficult to control costs. So in Canada, a single-payer system means that, governments who pay hospitals and who pay doctors are monopoly buyers, right? So they don't have to, they're not in a cutthroat competition market, and they don't have to compete with for-profit institutions. Whereas in the United States, even public programs are in competition for personnel, for goods, with private for-profit enterprises. And so that makes the medical game then is very different. It's played out very different in the United States than in Canada. And of course, the problem of the uninsured is something that we don't have in Canada. The problem of the uninsured being not only a social issue, right, that people may not have the insurance that allows them to be accessible for certain types of care, but also the problem of the costs of these uninsured on the economy. Right? So the idea that the uninsured are a drag on many hospital budgets when they show up for procedures or for care in emergency rooms, and that perhaps that's not the best way to care for the uninsured or anywhere else in that regard. Quickly then, what are the pressures on the healthcare systems and some of the key reform directions, if you will? And here what's interesting is that you're going to see that a lot of the challenges are the same in Canada and the US. They're just playing themselves out very differently. Here are some important questions that we're facing in Canada, and I think in the United States as well. The first question, and I'm going to summarize them simply as what, when, how, and who. So I'm keeping it simple, as they say. The first question would be, what services should be covered by health insurance plans? This is a big debate in Canada. What should be inside what we call the Medicare basket, right? So what should all the services be inside that Medicare basket that Canadians have access to? And as I pointed out, there are a lot of gaps. There's a pharmaceutical gap, right? There are some sophisticated diagnostic treatment gaps. There's the continual question about, well, will this breakthrough drug be covered by the provincial health plan or not? Because provinces sort of decide what the coverage of certain prescription drugs are for people who have who are eligible for those drugs in a hospital setting, for example. So these are big questions about what services should be covered by healthcare plans. And as healthcare moves forward, technologically speaking, these are going to become more and more important questions. In the U.S., these have implications both for public insurance and for private insurance, right? We saw the debates about, what should be under the Medicaid, what should be covered under Medicaid. But certainly as we go forward, it's going to matter in terms of private insurance plans. It's going to matter on sort of what are the limits to what we can actually pay for and what's the cost effectiveness of some of the drugs and other techniques that are coming into the market. The second question that's very prominent in Canada on healthcare reform is when should people have access to care? So this is the famous idea about why we have waiting lists and why there are backups at emergency rooms, for example. And here, this is, I come back to the fact that in most publicly funded healthcare systems, you're going to ration healthcare on the basis of need. And if you do that, it means people who aren't quite as in need or who have kind of medical conditions that aren't life-threatening, if you will, at that moment in time, may have to wait and may get pushed, if you will, further down the line. And the equal access provision, the fact that you money can't help you jump a queue is also a big issue in Canada right now. In the United States, obviously that's a huge question about when should people have access to care. And I think the more important question is where should they have access to care? Because probably, as I said, emergency rooms are not the best place to deliver some of the kinds of care that they're forced to deliver, not only for the uninsured, but often for insured patients as well, who are not using emergency rooms properly at all. This brings me to the third question, which is how healthcare services should be organized. And this is a huge question in Canada, which all the provinces are undergoing right now, is about primary healthcare reform. So, we have a good thing going in Canada, many people think, but it's still a problem in terms of how people get in the door of the healthcare system. Here's where I think some of the HMO models in the United States perhaps do a better job of suggesting where people should go for care, whether it's primary, secondary, tertiary, who they should be seeing, who they should be talking to, this idea of comprehensive care, this idea of actually having a team that is involved in the delivery of your health care. Not all HMOs do that, but in Canada we've sort of let that go. And people access care through their GP if they have a GP, or they go to a walk-in clinic, or they go to their brother-in-law's friend who's a specialist in whatever. I mean, it's just not coherent enough. And that's what primary healthcare reform is designed to do in Canada, is to make that coherent. And at the same time, think about how to better manage chronic disease, for example, how to better manage some of the challenges that we'll be facing, not only because of the aging of our population, but also because of some of these new diseases or new things that have been considered diseases, such as obesity and diabetes, type 2 diabetes, and how they are really transforming what we need in our healthcare system. And finally, and perhaps most importantly, the who question is, who pays for healthcare? So as I said, healthcare isn't free, is never going to be free, but at the same time, it's important to recognize that there's a free question about how free it is, and there's a freedom of question about how to pay for things. And I think that in Canada there's more and more questions about why all that payment should be going through a single payer, which is the government. Now, many Canadians will tell you, and many specialists will tell you, that it's the most cost-effective way of doing things, that you monopolize, you socialize the cost, right, and you reduce the kind of insurance problems that you have with cherry picking, the kind of insurance problems that you have with a basin of eligible insurance. But the question is, if that's the case, why, if I have some money, can't I do something else if I choose? And that, I think, is the big question that's coming forward in Canada. At the same time, though, in the U.S., when I talk to people in the United States, the question always comes up, well, I'm still paying a lot of money for health care in the U.S. It's eating up more and more of people's disposable income. And even Americans who don't like to be taxed and don't want to be taxed more are thinking, well, maybe all these hundreds of dollars that I'm paying out on premiums every month, these hundreds of dollars that I'm paying out in copays and deductibles and everything else every month, if that went into some kind of a fund or tax, maybe that would be a more efficient way to deliver and pay for health care. Right? So I think there's questions that are being asked on both sides of the border. The who question for Canada and the United States is also not just about individuals, but about governments. Because in Canada, the question is who pays in terms of, should it be the federal government that pays? Should it be the provincial government that pays? Because as you know, there's the golden rule, right? He who has the gold makes the rules. So if the money is coming all from the federal government, then the federal government can make the rules. And if more money is being raised and spent at the provincial level, the provinces can make their rules. And that's a federalism issue that's also an issue in the United States. It certainly was an issue in Medicaid reform, which had, on welfare reform in the 1990s that had a huge impact on Medicaid. And it's certainly an issue in SCHIP, as we've seen in the recent veto by President Bush, and the kinds of political machinations around that political program. Finally, and here I will end, where are we headed in health reform? As they say, politics abhors a vacuum, so in the absence of change, change still happens. And in Canada, what we've seen is, in sort of the absence of big legislative measures about healthcare reform, we've seen an erosion of public confidence. We've seen a little bit more investment, public investment in health, but still pressures for further change. I think that one of the take-home points is that in Canada, we've chosen to socialize the cost of healthcare, but and lessen the burden on individuals, but we've raised the burden on society, so that since we've socialized the cost, there's this huge collective cost. healthcare is now taking up 40% of provincial budgets. So if it's taking up 40% of provincial budgets, well, what about everything else the provinces have to do, like roads and, education and all these other things that they are responsible for? So the question is, is it going to be the dog that ate Christmas? I mean, is it one point where just healthcare and nothing else? So that's a big question about what the global collective cost to society is. In the United States, the cost issue is much more directly personal. It's about people's pocketbooks every day, and it's about their premiums every month. So the political lessons for that, I think, are worth noting. In Canada, politicians have realized that they play political football on healthcare at their own peril and at the peril of their constituencies. And if you think about it, a lot of the federalism problems that we have and a lot of the ways in which the federal government chose to cut its payments to the provinces, and the provinces had to go find that money in the hospital sector and healthcare sectors, it means that a lot of people suffered because of these political conflicts going on. And I think that that's part of the reason why public confidence is so eroded. People are thinking all these politicians are bickering at themselves, at each other, and that's why our healthcare system is becoming devalued, if you will, in some respect. The second take-home point is that every healthcare system imposes some rationing, and I think this is something that's important to recognize, even for Canadians. That if you want a universal health insurance system, choices have to be made about who gets what, when, and where. And we have to be comfortable with those kinds of choices. And if the basis is need, it's the basis of need. If you want to start making exceptions and have parallel private markets spring up, that's a choice that has to be made. And in the United States, I think the question is, can we go on rationing healthcare on the basis of ability to pay? Or is there a better way of thinking about what has to be done? And certainly some of the proponents, some of the adversaries in these primary presidential primaries we saw did have different takes on what needs to be done or what can be done to try to regulate the problems that are associated with healthcare as a commodity rather than as a public good. And overall, then, to conclude, there are similar pressures in the United States and in Canada, and they are grounded in very different political realities and different contexts of existing healthcare systems. And in many respects, these differences have endured, and healthcare in Canada and the United States remain quite distinct. And since they are at different starting points in health reform, it's unlikely that the two countries will converge anytime soon. But in the past 20 years of observing healthcare politics and policy in Canada, it's obvious that satisfaction in Canada is eroding, and that old saying about Canadians being kinder and gentler or whatever, I don't think inoculates them against change in any direction. I think that what matters is whether the healthcare system, and this goes for Canadians as well as for Americans, is living up to the needs, and increasingly not just needs but expectations on whether the healthcare system functions properly and whether it will be there when people need it in the future. And I think all of these things have been sorely tested, not only by current economic and fiscal conditions, but also by political and social actors playing political football with healthcare. And I think that the comparison between the two countries reminds us that politics and policy are equally important in healthcare reform. Thank you very much.
Okay, we have time for a few questions. We are going to finish at 10 minutes to the hour, so don't get too restless about that. And we do have a mic, so if you put your hand up and we'll get the mic to you so you can ask the question, and everyone will be able to hear what you are saying.
Do you have a co-pay program in Canada? Do you have a co-pay program of any kind, and do you think it would be a beneficial thing to control people who just like to drop in and people who need to drop in?
That's a very good question. We right now don't have a copayment. Copayments are not allowed under the Canada Health Act, so hospitals can't impose them and doctors can't impose them. On the question of whether people misuse or abuse the system, this is actually a point of contention among different political actors, some of whom think this does happen and some of whom think it doesn't. But now provinces are getting a little bit more wise, I think, about not only patients misusing the system, but also doctors who are billing too much. So there are continual audits to see what's going on. And sometimes, though, a person who's dropping in too frequently, it's because they have a chronic condition that's not being managed properly. So sometimes it's not, purely psychosomatic, if you will. There is sometimes something going on with the person's healthcare need that needs to be better addressed. And we're trying to do better on that. But one of the reasons we can't do as well as we should be doing is that we don't have electronic health records in Canada. I am amazed that the two most sophisticated healthcare systems in the world, in Canada and the US, don't have electronic healthcare records. Taiwan just recently redid its healthcare system on the basis of electronic healthcare records. That was the first basis, and then they moved up from there. So until we can get some kind of more coherence in knowing how people use the healthcare system, it's going to continue to be a problem. Oh, another really good question. So because doctors belong to provincial, they're not unions, but they're associations, and because these associations negotiate as a group directly with the provincial government, malpractice rates are very low. They're higher for some subspecialties, as you can imagine, such as OBGYNs, but they're still much lower than they are in the United States. That's the first reason why malpractice is not as much of an issue. The second is that in Canada, it's very rare that in a civil court, damages are, that juries will award cash damages to, even if the plaintiff wins the case. It's very rare that juries can award cash settlements, so what's the point in many respects? If the point is just to see that there's wrongdoing, that's different, and that's different in criminal proceedings. But the justice system is different, and the way that doctors belong to a collective group that can lobby on their behalf is different as well. So malpractice is not the issue that it is as it is in the United States. I think there was a question. I can hear you with that. I can repeat the question to you.
The universality of the system, you said you have to be a legal resident
yes.
of a province, but is there provision for illegal residents?
We don't have illegal residents in Canada. Oh, that's right. I can speak honestly here. Yes. We don't have, relatively speaking, as many illegal residents in Canada. Let me put it that way. And we do have a refugee system, however. So if you're a refugee or if you're applying to be a resident in Canada and you're not yet a legal resident in Canada, the federal government picks up the tab. So you can access health care, and the provincial government bills the federal government for the care you receive until you become a legal resident. So we don't have provisions for illegal residents, though they can obviously go to an emergency room as they can here in the United States. But we do have a provision for refugees or for people who are waiting for their legal residency status to be decided. So many people come in and claim a status, and the Canadian government says, well, we'll have to take it to the Immigration Review Board or whatever. During that period of time, they're still covered, but not by the province. I think there was a question here, yes.
Are Canadians using medical tourism to get around the implications of rationing by need rather than by monetary ability?
Medical tourism comes up in two respects. One is for what we would call non-urgent surgical interventions, such as hip knee replacement, for example, not so much cataract surgery, but hip and knee replacement or cosmetic surgery. In this case, some Canadians do engage in medical tourism, or they can engage in the kind of private practices that have been springing up in big Canadian cities, so that you can, for example, do many of these cosmetic and other interventions in your big city if you live in Montreal or Toronto or Calgary or Vancouver, and you can pay out of your own pocket for them. So some may be tempted to go abroad. The problem with going abroad, though, is if you come back and you have a problem, that problem then becomes the problem of whoever your provider is in the public system, right? Because all of the things that couldn't go wrong after that. It's not I wouldn't say it's a big proportion of Canadians yet, and in part because some of the demand is being fulfilled by these, Canadian enterprises. The second thing I would say is that medical tourism comes up when it's a specific procedure or a specific kind of drug treatment that is not available in Canada. And again, this is a very rare basis, and then Canadians might be tempted. However, medical tourism doesn't get around the question of money, which is it's still very, very expensive if you can't insure yourself, right? If you don't have any insurance for that particular because it's not covered under a private insurance, you're not allowed to be covered under private insurance. It's difficult for you on a monetary basis to be able to do that. But there are specific cases of medical tourism. People go down to the Mayo Clinic, for example. Then I think Canadians are in a global market, right, that they see that there's this one procedure that can help them, or this one miracle drug that people are touting that are not covered by provincial plans, and they may try to find it. Yes?
How are these, you talked about some private hospitals that are obviously for-profit.
Mm-hmm.
How are they fitting in then to the system you just described?
They don't fit in. That's the thing. There's a wall, and the wall is that what's public is public and what's private is private. Doctors in the provincial healthcare plans have to decide whether they want to practice for-profit or public healthcare. What I mean by that is a doctor who bills a provincial government is not allowed to bill any other way, right? So if you're a doctor and you're making a nice salary by billing the provincial government for all the people that you see, you're not allowed to go out and moonlight or to set up, half a day or a day in a private institution. There are not that many of them, but you can't do that. And one of the reasons that the challenge there is, what do we do about human healthcare resources? And the challenge for the doctor is, should I go and give up this, this card is, as some of my more cynical friends say, a license to print money, right? Because it's all good, right? You bill and you get the money back. There's no bad checks. There's no bad deals. Should I give that up to go into completely private practice, in which I don't know if I'm going to have a client base, because clients can't be insured for the procedure that I'm doing, right? Let's be frank. And I don't know if people want to pay twice. They want to pay taxes and they want to pay out of their pocket. It's not clear that Canadians are ready to do both. So it's curtailing, they do exist, but it's curtailing their growth. There's a lot of pressure, however, to have that wall come down and to let physicians practice in both theaters, if you will, as there is in Britain.
Would it help to reduce some of those waiting lists, this waiting time, if those private institutions were able to practice?
That's one of the arguments. The counter-argument is that it's the same person providing the service, right? So if you siphon off your healthcare professionals to work and allow them to work in the private sector, then you're taking the kind of time they could be using in the public sector, right? And then you're redistributing that time on the basis of people's ability to pay, which is